Hi, welcome everyone to Medscape. It's with great excitement that I present today a friend and colleague, Lorraine Kalia. Professor Kalia is a senior scientist at the Krembil Research Institute in Toronto, and she's also a neurologist at the University of Toronto. And she's just been prolific. We use her graphics many of the times in our slide deck, a great clinician and a scientist, bringing you today some knowledge about clinical trials. We're excited to talk about a very hot topic. The GLP drugs, and I am Dr. Indu Subramanian. I'm based at UCLA. So welcome, Lorraine.
Hi, Indu. Thanks for having me.
I was excited to read your commentary in the Lancet about the GLP trials. Perhaps we could just start with your thoughts and maybe just a brief introduction about GLP drugs and where they fit into neurodegenerative disease and Parkinson's specifically.
Yeah, for sure. I'm sure that the audience is aware of GLP-1 receptor agonists as they've been such a hot topic with respect to treating diabetes and probably more so around treatment for obesity. But they've been heavily investigated for increasing number of indications around those areas. Sleep apnea, osteoarthritis of the knees, cardiovascular disease, and in the field of neurodegenerative disease, which is obviously near and dear to our hearts, they've been heavily investigated with the idea that there might be a component of insulin resistance that leads people to be at risk of neurodegenerative diseases, Parkinson's disease, as well as Alzheimer's disease, and that maybe repurposing these drugs for neurodegenerative diseases would have some benefit. And from the laboratory side, I mean, there have been tests of some of these GLP-1 receptor agonists in Parkinson's disease models that show that if you actually give them peripherally to animals, you can reduce the neurodegeneration of dopaminergic neurons. Importantly, there's also some epidemiological studies that suggest if people have been treated with a GLP-1 receptor agonist, they are less likely to develop Parkinson's disease. So with all of these different lines of evidence, there have been now a good number of clinical trials actually testing the hypothesis that treatment with a GLP-1 receptor agonist will slow the progression of Parkinson's disease.
And I think it's an exciting group to look at because we don't have to do a lot of the safety studies just in general, right? Because we are basically repurposing a drug that's already out there. Maybe you could just briefly summarize the studies and what they've shown to date.
Yeah, so there've been a number of studies running up to this phase 3 trial of exenatide that was relatively recently published in the Lancet. Similar to the preclinical and the epidemiology work, there was a lot of signal there that suggested some benefit. So a phase 2 trial using exenatide in individuals with moderate Parkinson's disease on dopaminergic therapies showed that there was a slower progression or an increase in the number of points on their motor scores. A study using exenatide, which is another GLP-1 receptor agonist, also showed something similar. And so I think myself and probably you and many others in the field were really anticipating what the results of this phase 3 trial was going to show. It was a big study, approximately 200 participants, multi center, which was different than the phase 2 trials, which were tended to be single center. So I think it was 5 or 6 UK sites, and long for a Parkinson's disease trial. So almost 2 years, like a 96-week trial, which I think is important when we think about a slowly progressive disease. And we can ask questions as to whether or not some of our earlier trials, which didn't capture any differences, was because maybe we didn't wait long enough. But this was I'd say, a pretty good trial in terms of length. The primary outcome for this was the same primary outcome that they saw benefit with in the phase 2 trial. So, learning from the phase 2 trial and hoping that that would translate to the phase 3 trial, which was basically motor scores in the off state because all of the patients who were enrolled were on a dopaminergic therapy. And unlike the phase 2 trial, there was no difference between the placebo controlled group and the group that received exenatide. And one could ask, well, was that the right measure? We always have discussions around whether or not our outcome measures are sensitive enough, or was that the right one? But all of the secondary outcome measures, so all of the other measures on the on the MDS-UPDRS, MoCA scores, quality of life scores, how much dopaminergic therapies had to be changed over the course of the trial, were absolutely identical, basically, between the two groups. So there was like no signal in even any of the secondary or exploratory outcomes. So really negative across the board.
Yeah, I think the patients have been really hungry to see the results of this trial. And I don't know about you, but I know there's been some patients. I mean, I think everyone and their mother is on a GLP drug, it seems like. And so people have been trying to use some of these even off label and acquire them and, get them made in compounding pharmacies and stuff.
Yeah,
And
and I think that's a great point that you bring up that I thought was useful for discussion also is, if patients come to you and say, "Can you just put me on a GLP-1 receptor agonist even though there's no indication for it?" I mean, my own, especially now with a negative trial, would be that there's really no indication to do that, especially in the context of no benefit and potential for side effects.
let's talk about the side effects because I think, one of the things that I've been really interested in is actually weight loss and Parkinson's. We've been doing some work on women, especially Asian women like you and me, and who may have lower body mass and end up, getting dyskinetic and sometimes getting into the cycle of losing weight and getting very frail. And then sometimes, bone fractures, fall risk, and other issues can come up. Maybe we could talk a little bit about your sense of that.
Everyone's concern around the GLP-1 receptor agonists in a Parkinson's disease population where you don't want people losing weight per se was a concern that if that's going to be the side effect of these drugs, that it's going to increase frailty. Um, at least in this trial with Exenatide, the extended release version in the phase 3 trial, there wasn't as much weight loss as had been seen in prior. One could wonder if maybe that was then an indicator of maybe not sufficient dosing. That's just for speculation. And I guess, as expected, for anyone that's familiar with the side effects around GLP-1 receptor agonists, is there was GI side effects, so GI upsets and diarrhea, and then non-specific things. But overall, if we were to look at the silver lining, I guess, in the trial, is it demonstrated, as did the phase 2 trial demonstrate, that exenatide actually can be well tolerated in a Parkinson's disease population. Whether that's the case for all GLP-1 receptor agonists is obviously not known, and perhaps some that are much more efficacious at weight loss will still probably need to be cautious as to that kind of side effect or that effect that people want in a non-Parkinson's disease population, and how that might have negative ramifications in a Parkinson's disease population.
We do have to, weigh the risks and the benefits, and I don't personally see an indication at the moment either. Um, you brought up also, I think, a point about Lacebo. Maybe we could just talk about Lacebo. Tell me about that. What is that?
Yeah, and I brought that up again, entirely speculation. It was related to the amount of weight loss seen in this trial was not as much as anticipated. And obviously, participants in these clinical trials are very likely going to know something, if not a lot, about GLP-1 receptor agonists, knowing that they're in a placebo controlled trial, knowing that they might be on placebo versus exenatide, that if they weren't actually experiencing weight loss, they may have assumed that, and so then the effects that come with a placebo effect are actually absent. But that's entirely speculation on my part to try and explain why maybe the differences seen in this trial were not as obvious as they had been in the previous phase 2 trials.
So much to consider and so much complexity. Well, thank you so much, Lorraine, for joining us today. It's just been a pleasure to talk about this rather complex area and get your insight.
Yeah, thanks for having me. It's a great chat.